Right, hello everyone. My name is Julian Bedford of Instinctive, and we're the Navilas distributor in the UK and Ireland. It's my pleasure to introduce to you today Mr. Sanjiv Banerjee. Sanjiv is a consultant ophthalmic surgeon at the University Hospital of Wales, Cardiff, and has previously been an honorary lecturer at Cardiff University. Sanjiv has a special interest in cataract surgery and medical ophthalmology, including diabetes and age-related macular degeneration. Sanjiv has been involved with clinical trials in the use of anti-VEGF treatments and photodynamic therapy for macular degeneration. Sanjiv is currently the clinical lead for diabetic eye screening in Wales. Today, we're going to be talking about incorporating allied healthcare professionals into the delivery of retinal laser systems, particularly using Navilas. Sanjiv, you've had your Navilas for about 4 years now. Could you explain how the decision to include Navilas technology at Cardiff and Vale Health Board came about?
I've been aware of Navilas for many years, since almost when it was first launched, and obviously at that point it was a unique new form of delivery system which we hadn't encountered, and we weren't particularly sure how it would fit into regular practice. But the onset of COVID provided a unique opportunity with the use of Navilas, and that's because the ability to have a non-contact delivery system for laser. And if you put your minds back to that period in early 2020, when people were very scared, both as ophthalmologists, and initially there was a fear that eyes are quite an important source of spread of the disease. It was quite important. We essentially had two options: not to do anything for the diabetic patients who needed urgent PRP and then could potentially lose sight from vitreous hemorrhages because they would then go on to need surgery, or we could try something, and that's where the Navilas came in. It's a non-contact method of delivering PRP laser was what really attracted us to get it in that place.
It's interesting that you highlight the non-contact ability of Navilas. That's really interesting. But let's dive right into the headline topic of retinal use by allied healthcare professionals. The role of and for AHPs has been expanding since corneal cross-linking anti-VEGF injections came about. Could you give the audience an insight into the background of retinal laser use by AHPs in the UK?
There is no long tradition of this. AHPs have used YAG lasers in various different, which is not for retinal, but mainly for capsulotomies and such things. But retinal lasers has always been the preserve of ophthalmologists, and the reason for that is quite a few. One is the use of a lens to on the patient side to focus the laser, and then because of the inverted image that these lenses often produce, then there's the need for whoever is using the laser to be aware of these challenges. So the delivery technique of a conventional or other forms of lasers through a contact lens has many facets to it, which make it quite a complex thing for a non-ophthalmologist to learn and be au fait with. But if you think of the way that the Navilas is delivered, which is on a screen where you can see the picture and you can see the laser firing onto the retina, it's a bit like playing a video game or an arcade game where you have a joystick in your hand and you fire your shots at your target. And that is a skill that a lot of people who are not ophthalmic would be very familiar with, and the other and just to bear in mind, the thing about the inversion of the image is not something that you would have to face with allied healthcare, other professions using the Navilas. So these are the unique features of this technology, which allows people who have not a great deal of ophthalmic training to use this laser. Um, or, and in our case, in particularly in Cardiff, this was something that we were quite keen on pursuing once the pressure had COVID had been overcome to a little bit, and to try and see whether we can use it with other allied health professionals.
So COVID was the instigator, but there were very valid reasons as to why the Navilas could be used by AHPs in a more general and less specific setting. Very interesting. But over and above that, were there any more specific local circumstances that prompted Cardiff to consider AHPs for retinal laser delivery?
I think one of the things that we suffer with in Wales in general, and probably in a lot of other parts of UK, it can be quite difficult to recruit middle grade doctors and people who traditionally have provided the backbone of the retina, diabetic retinal, particularly doing the lasers. I must acknowledge that, like, a lot of the work has shifted on to the use of anti-VEGF, but there is a substantial chunk of patients, both with diabetes and retinal vein occlusions, who still need a lot of panretinal photocoagulation. And in most places, these are done on the day of clinic. It's sort of a clinic procedure almost, where it's not like doing a cataract or something where you book a separate day. We by and large try and provide a one-step solution whereby all the patients come to the clinic, and whoever needs treatment is treated then and there. So there is a need for the treatment to be not only easily deliverable, and to have a pool of people who can deliver this, and that particular reason helped us. Drove us to trying to use the Navilas with the allied health professionals.
So having an idea to introduce AHPs to retinal laser is one thing, but letting them loose, as it were, on the laser to deliver treatment is another. What work was required to set up the AHP program?
It shouldn't be any different to what one would need to do to set up nurse injectors and programs which are widespread use in the UK. The usual pathway is to describe the need, and then to develop a patient group directive, which is sort of saying, identifying the conditions that and the procedure that will be performed by this allied health professional, and then also describing a training program and regular assessment of that, the functioning or the performance of the person who's been trained. As soon as all these are in place, a PGD can be signed off by the clinical governance lead in the hospital.
And how long did that take to set up in your case?
It can take anything up to 6 months, depending on and there is a fair bit of local variation in this, in terms of how much need there is for the particular service, and if there is a awareness within the management team that there have been problems or complaints or things where people have come to harm or delay in treatment because adequate staffing was not available. Any episode like that can be used to push through these directives.
So with regard to staffing, what is the typical background of an AHP that uses retinal laser now? And did you select them, or did you ask for volunteers?
A bit of both. I mean, obviously, the person being trained has to be interested in doing this. And it is always useful to have somebody who is familiar with trying to examine eyes. We all have a lot of nurse practitioners who assess patients for cataracts, do biometry, and try and look at the fundus with through a slit lamp biomicroscopy. So they're aware of how to. I mean, so I would say the basic somebody who's able to use a slit lamp is important, because that is the guide to be able to focus focus the laser, and also an ability to work through a screen and joystick, so which is something that typically you'd have to do if you're doing biometry for cataract patients. So if anybody having those two basic skills is probably somebody who's suitable to do this.
Very good
But
to
this
know.
should
Thank
not,
you.
sorry, this should not be an exclusive criteria, but because there may be photographers who might be quite good at doing that as well. We did look into getting photographers, but there is an element of reluctance in that group to get directly involved in what is essentially a clinical work, whereas people who work with patients' eyes, like the nurses, are more amenable to being involved in such a project.
That's an interesting observation. That hadn't occurred to me, certainly. So we've got a profile group of AHPs now. How practically is then Navilas used in the department? How do AHPs do the work that's necessary?
So our laser sits in a room that has to meet the standards of lasers, which is separate to the clinic room. So the patient would come into the clinic, or either myself or the AHP would see the patient. We are most diabetic patients these days have an Optos picture done. We would look at the picture together, and if particularly if they're new vessels, if we identify new vessels, we would suggest that the patient start laser. Once that decision and the consents have been obtained, I would take the patient across to the laser room. And the initial step is obviously to learn to take a good quality picture. Now, I must confess that that was also quite a learning curve for myself, because that's not a skill that I had previously and had to learn. So a couple of things that I have found particularly useful is you must put some sort of although this is a non-contact technique, using a topical anesthetic is useful because it reduces the blink rate, and ideally in both eyes, because if one eye continues to blink, the other eye would automatically blink. So that's one of the things we do. Now that the HP is in the room, initially, I would take the picture and get them to do the same. And obviously, you can't keep practicing on the same patient. So, try not to do more than 2 additional pictures, and remember to delete them, because when this patient then subsequently comes back, it can cause confusion as to which is the picture that you were working from. So delete the ones that you're not going to use, don't store them. So once you've taken the picture, then you explain to them how the mapping is done, the spot size, the power, and how to titrate the power. That's probably the safest way to start people using the laser to do the titration, single shots, and they can see how you get a feel of actually doing it, rather than letting them lose straight away in doing the PRP. So once they're familiar with doing the titration, the next step would be to do the plan, and once they've seen you laser, you can then watch them complete the plan. Ideally, start with the 50 or 100 shots left to do, and that's when you hand them over so that they can continue. Once they're familiar with the process of doing the laser, the next step would be to try and start doing the PRP, because obviously once you make the plan and then to start it, there is a bit of adjusting that needs to be done, because the patient may have moved while you were making the plan. So you have to bring them back into so that the image, the plan and the image match each other. So that's the next learning step before finally letting the your AHP start working on the plan. You can then go on to, if your PGD includes this, that they will do the planning of laser. You can teach people to do this, but we haven't as far gone ahead to do that. But we did initially think about it, and the way I would suggest is to start off with fill-in PRPs, where you identify the area on an Optos or something like that, and then identify the same area in the pictures taken and fill it up and do the PRP there.
Now, you mentioned you've got 2 clinic rooms, one laser room, one clinic room. How do you practically manage and treat the patient during the clinic session?
So now that we have our fully trained AHP, what I tend to do is once the patient has been identified and yes, they need PRP, all the consent and everything is agreed upon, the patient goes ahead and I hand over the patient to my AHP, who takes the patient across to the laser room, takes the picture, and then and in that time I finish writing my notes and dictation, and then I pop round to the laser room, which is just just around the corner, and then complete the map. Once the map and the power has been and nowadays I don't even do the titration, so I just do the map and then I leave the HP to finish the laser and I move on to the next patient. And as you can see, this allows us to see a much larger volume, because it is almost as efficient as having a junior doctor. In previously, I have the same numbers with an AHP that I would with a junior doctor helping me or a staff grade helping me in the clinic.
So you've been running this program now for a little while. How have you measured the success of the introduction of AHPs?
I mean, there are 2 aspects. One is obviously the introduction of the Navilas and the introduction of AHPs. And if you talk about the introduction of the AHP first, it in one fell swoop, once the person's been trained, it has allowed me to increase the clinic capacity by almost 50 to 60%. So which is hugely helpful. Then furthermore, what I do now, sir, when there are patients who are on a plan PRP treatment where the plan has been made, even if I'm away, the AHP can continue to, so the clinic doesn't go down if I'm away for whatever reason. So this has allowed us to increase capacity significantly. So that's the big advantage or the big benefit that I'm seeing with the introduction of AHPs into the service. The other benefit is obviously the Navilas itself. A lot of patients find it a lot more comfortable. We do from time to time get referrals for people to have photocoagulation under a general anesthetic or anesthetic because they haven't been able to do it in clinic. This was a particular issue in some of the peripheral hospitals during COVID, and quite a few of them we've managed here at university to do them under just using the Navilas, because a lot of patients find it hugely helpful. And herein is the other bit of the benefit of having an AHP, because with the AHP I can then give her, she can take he or she can take a longer time to do the laser, while I can carry on with seeing the patient and dealing with them, and doesn't hold me up for a longer period of time.
Yes, because the capacity, as you've said, has increased by changing the workflow, basically.
Yeah.
And am I right in thinking as well that part of that workflow change, you now see injection patients and laser patients in the same clinic?
Yeah, so this allows us, because if the HP is trained to do IVTs as well, particularly for PRN patients who are stable and need intermittent injections, we can see them in this clinic, because if they need injections, we can do them. If they need laser, we can do them. They are not, we don't have to streamline them into different pathways where you then have to wait for one thing or the other.
That's a really good use of time, being more efficient. Sounds wonderful.
Making it a one-stop solution as opposed to having more than one stop.
So what one visit could see the patient
Exactly.
mean the patient has a number of treatments or interventions during that one visit rather than just one.
Yeah.
Now, you've trained the AHPs. How easy is it for an AHP to learn Navilas? How long does it take? And have you got experience of training AHPs with other laser systems?
No, I mean, we haven't tried with other laser systems, but yes, we have trained people with YAG lasers. It is a lot easier than training somebody to use a YAG laser, because when you're using a slit lamp by microscopy to deliver the laser, it is up to you to maintain the focus, and you have to coordinate it. Everything is in focus and then fire the laser. Whereas here, that is dealt by the machine. You're looking at a screen and you're firing, and you're not that worried because if it goes off focus, because the machine will automatically not fire the laser. So it gives a level of confidence which makes it a lot easier to train, and as long as the person you're training understands that, it shouldn't take longer than 3 months.
Well, that's really is quite a short period of time, really, to get another user fully trained. So we've not had experience with other lasers. Do you think it would be possible to train AHPs on retinal laser on other laser systems in the same way?
I don't think it will be that beneficial. I think the whole purpose of training an AHP to do Navilas is to increase capacity, improve efficiency. Going back many years when PDT was available, there was a push to train some AHPs to doing PDTs, which also involved delivery of a laser and everything. And it was not, it was a difficult process and not very successful. So Navilas is much more user friendly and particularly beneficial if you want to get AHPs to use it. It opens out a whole new way of delivering retinal care particularly for diabetics and retinal vein occlusions.
So you say that the safety features have really allowed you to push forward with the program, the pre-planning, the eye tracking, and we've not mentioned the caution zones yet, but
yes,
in the round that must give a lot of confidence.
Yes, I mean, yes, once you've identified the caution zones, and And for that matter, if you're unsure whether you can put your caution, as many caution zones in this, that like if you want a particular area to be lasered, you can cover the rest of the picture with caution zones, and the laser will only work in the affected area. It works for both ends in the sense that it's a lot easier for somebody who is unfamiliar with the optics of slit lamps and all these lenses and magnifications and things like that. And also, as a trainer, you have a greater confidence that you're not going to suddenly get somebody having a macular burn or a burn on the optic disc, which then leads to litigation.
No, of course not. Nobody would want that at all. Excellent. And the digital nature of Navilas, the digital record that's kept of both photographs and treatment plans, you've alluded to that, can be a safety feature, as it were, in terms of patient management.
Yes, absolutely. I mean, so for instance, if as my routine, I treat people, tell the people to make the plan, and then once you've finished doing the laser, take another picture. So there is and then when you go back to review, you can then look at it and say, this was the plan, and this is what we have achieved. So there's a photographic record of what has been done and whether it matches the plan or not. And this is a very this is a unique feature of the Navilas, which makes it particularly beneficial in the context that we are discussing today.
And you mentioned the need for anaesthetic in both eyes. Are there any other special steps needed in prepping patients for treatment?
The other thing, I mean, particularly if your patient is very is a difficult patient, turning the light down, and the fact that there are no it is an infrared tracking system makes it a lot easier for us to use the laser, and it allows you to do, I've done 1,000 burns in patients who have previously you've not been in other machines where they've struggled to do anything more than a couple of 100 burns in a session very quickly. So once you get familiarized with the technique, it's a fast, quick way of delivering laser to all sorts of people, or with various level of apprehension about the laser treatment.
Okay, we've covered a lot of ground there, Sanjiv. Thank you for that. And as we get to the point of wrapping up, could you say if there, what are the aspects of Navilas that other units might encourage other units to look at AHP training in particular?
I think the biggest, it's an easy thing to teach. I mean, once you've learned yourself, you will know it's a fairly easy thing to teach. You have a screen, so you can, so both while you're training, the trainee can see what you're doing, and while you're overseeing the trainee standing, you can see exactly what the trainee is doing. It's a bit like when we teach people to do cataract surgery. When you're looking down the side piece, you can see exactly what they're doing. You can tell them to stop, or correct their whatever they're not doing right, which is not something you can very easily do in any other form of laser training that you might do. In most other forms, the usual method is you show them a few times and then you let people get on with the laser, and then you check later on whether it's been done. You can't contemporaneously adjust things to help them to do what they're doing.
I see. And can you see any insurmountable hurdles for units in looking to either start an HP program or introduce Navilas into the program if it already exists?
I don't think there may be hurdles, but I wouldn't say that there are unsurmountable. All health boards and CCGs and trusts have particular needs. I mean, if you're struggling to to get a Navilas, one thing that always attracts the funders is your ability to provide this care closer to home in a in a more community setting. That is always an attractive selling point, whatever the other objections are. And obviously, if you have a waiting list, or there have been complaints about people losing their eyesight because of delay in treatment for diabetes and things like that, these can also be utilized to support the application of this technology. The most important thing in my mind in getting a Navilas, it is a lot kinder to the patient receiving it, and ultimately we as clinicians always want what is best for the patient.
Mr. Banerjee, Sanjiv, thank you very much indeed for your time today, and that was a really comprehensive overview of the AHP program at Cardiff, and thank you.
Thank you.